the victim the best chance to survive. I brought an AED and just to show you what it looks like.
Okay.
This is what's being used prior to our arrival.
Compression starting time.
I'm going to talk through what's going on. You feel free to get and move around if you want to take a look and see what's happening. On the screen, what Chief Smith is displaying is a close-up of the cardiac monitor. What we're seeing on the cardiac monitor at this time is what compressions look like. First thing, company identified the person's pulses and non-breathing. Again, if this was ideal conditions, hopefully someone on the scene is starting CPR before we get there, and or our dispatchers have been capable of able to talk someone through initiating CPR prior to our arrival. The crew is taught to work in a coordinated fashion, to talk out loud, to communicate, very important. To establish different places for our equipment to go, so we know the proper equipment is coming in, and it's placed at certain parts around that patient, so it's efficient for those people who have job assignments. Each person coming through the door has a specific assignment. Dave Nagel is currently performing CPR. He's the engineer of the fire apparatus. His job is going to be to alternate CPR and work with the airway, along with firefighter Fuente, who's working on the airway right now. What you're seeing on the screen, that green line represents the cardiac rhythm, which we're seeing with something called ventricular fibrillation. The heart essentially is supposed to pump in a sequenced event to get good circulation throughout the body. When it's in fibrillation, it's just quivering. So it's moving, but it's not producing or moving any oxygenated blood throughout the body.
We're at minute 30.
The bottom portion of the screen, you're seeing the purple area is our compressions. We have the ability to get instant feedback on our cardiac monitor to understand the quality of our compressions. There are three things we're looking for in good compressions. A rate of 100 to 120 per minute.
Right, charge.
We want to make sure we have the proper depth. More than 2.5 inches of compression. And what's really important also is recoil. If the heart does not allow it to refill, when you compress it, you're not pushing anything out.
5, so 4, 3, 2, 1. Clear. Clear. Pressing. Shock. Switch.
If we don't allow recoil, we can't put good volume out again. Now, what we just witnessed was a defibrillation. So the part of the treatment for a cardiac or ventricular fibrillation is to shock the heart. And in layman's terms, I guess we could say, we're all familiar when our computer's locked up, we use the reset button. We're trying to do that to the heart. We're trying to electrically reset the heart so it fires in the right sequence. Lieutenant Moore is kind of running the call right now. He's managing the scene. What's taking place, Engineer Nagel is operating what's called a BLS, or basic life support airway. He's helping to breathe for the patient. Firefighter Nagel at the feet is helping to obtain an intravenous line. He's using an intraosseous. We're putting an IV in the bone. Essentially, when we have poor circulation, we can't get into the veins. We have an opportunity to go into a bone where we get good perfusion. Also dispatched to the scene is the battalion chief. The chief is assigned to come to the scene because oftentimes we have family members, bystanders who have information, also who are very distraught or upset. This is a very traumatic event. So we need help in getting information. We need help in also keeping those people in a safe position. We want to understand they want to give their loved ones. We also have to be able to work. So the battalion chief is there to help coordinate companies.
Joe 70ET.
70ET, we're at.
So we have an endotracheal tube. We put a tube into the trachea so we can breathe for that person. It's a very positive airway. We're not getting other fluids or other items in the airway that can obstruct it and make it more dangerous. We're establishing an IV at the leg so we can administer some medication to help the cardiac arrest situation.
MPN 336.
Charging.
Again, the crew is talking, explaining what they're doing. All this is prescribed. We're not making any of this up. We operate under something called standing medical orders, where the doctors have told us these are the steps you have to follow. And it comes in the form of an algorithm.
10, 9, 8.
If we talk out loud when we shock, no one can touch the patient or they will get shocked also.
3.
It'd be bad for a heart that's beating normally to receive a shock.
Clear.
Clear.
Charge.
Shock. Go.
Switch.
Okay, so we're allowing compressors to go for no more than 2 minutes. If you're doing 100 to 120 compressions a minute at 2.5 inches of depth, and also proper recoil, it's very tiring. We could probably do CPR for half an hour, but we're doing bad CPR. So what we decided to do is our compressors are going to go for 2 minutes. They switch out. Notice that Firefighter Fuente is not compressing right now. He's helping with other activities along with this full rest. So when it's time to switch again, Lieutenant Moore will call it out. Firefighter Fuente is ready to come in and take over. We want to be as seamless as much as possible that we don't lose a beat. Again, we get direct feedback on what's going on with the patient and the heart rhythm, and also how good or effective our CPR is. I want you to notice that the amount of equipment we brought into the scene here. We've got a cardiac monitor defibrillator. This white and orange box is a drug box. Our medications are inside this container. We have an airway kit. We have a suction unit. Sometimes people have airway blocked with a variety of things. We have to get that out of the airway also. So we're bringing in some basic equipment to help manage this. An oxygen bottle. The blue bag that's being squeezed is called an ambu bag. It helps breathe for that person so we get a proper amount of air into the lungs. We have a prescribed code that we're following, which includes compressions, respiration, and also drug therapy, medication therapy.
Okay, 15 seconds until charging.
So we notice they're calling out, there's 15 seconds before the next time it's time to defibrillate, or try and reshock that heart and get to the right rhythm. The next group of folks you're going to see coming in, right now we have 2 companies on the scene. This represents an ambulance and a fire engine. All right, now, all 5 of those people are working. Now, when it comes time to move this person to go to the hospital, who's going to be able to do that? We're sending additional people. Clear people back in who are going to be involved in patient transfer. If it's a case where it's a prolonged CPR event, where we need to change compressors, where we get tired, or we move people around, tight spaces, these other gentlemen come in and they can fill in those roles. Everybody's cross-trained in all these spots. Depends on where they're sitting in the apparatus that day, depends on what job function they're going to follow.
Sign us on the monitor.
We've been training all along to fill all those roles. Notice the green line on your screen right now has changed.
We got to sign us on the monitor. Hold off on the emptiness.
Okay. Except for that, we're blocking our camera.
Please.
Raise head.
Can we raise it?
Okay. So the green line on the monitor represents a normal sinus rhythm. Means the heart is now beating like it should. If we took a cardiac tracing and most everybody in this room we're expecting to get this type of tracing. This is what it looks like for everybody here. So what this represents is that we have a good heartbeat. Now notice the compressions are still ongoing. Now the heart has stopped for a period of time. It's still not caught up. It's not at full speed. So we assist it. Another minute of CPR after we get a proper rhythm, and we're verifying we're checking for a pulse. We want to make sure we get a pulse, and we're also checking for a blood pressure.
70, Joe.
So we got a pulse, we got a blood pressure in our example today.
Ready, Griff?
Okay, which means the heart is beating on its own and producing sufficient blood flow that is pushing oxygenated blood throughout the body to all the proper places.
1, 2, 3.
So now this third crew's coming in, they're working together, talking it out. The first person on the backboard, that rhythm may be unstable. We don't know why they went into cardiac arrest in the first place. So we're prepared in our equipment, and we're managing this call. If we have to go back to compression, we're able to do that. Our IV's still in place. We're still breathing for this person. Now it's a coordinated system of packaging, getting everybody together, put our patient on the cot. Other things take place that aren't seen here. Put the ambulance in the right spot on the street. Get the snow out of the way off the driveway or the step. Moving furniture to allow cots. Most houses don't allow for these ambulance cots to come in. If you rearrange things so we can move in and out more efficiently. These are other things that these crew members are doing while the first crew is attending directly to the patient. So we have the patient families being managed with the battalion chief. We have extra players to come in, extra members to come in and help move the patient. And lastly, the last thing that the extra crew does along with the chief is to make sure that we don't leave anything behind: our drug box, needles, equipment, tools, etc. So we just did in about 10 minutes. It's fairly typical.